Morning to everybody. Thank you for the invitation. I'll be with you shortly for the next session, so online for this one. And coming to the TTTVR area, we know from the recent guidelines that transcatheter tricuspid intervention has been upgraded to 2A under certain circumstances, and all the previous speakers have delved into the details about selection of easy, moderate, or difficult cases for TEER or not to TEER. And they've also delineated all the details about the predictors of a good outcomes and how to use scores that incorporate all these predictors and try to guess if TEER will be successful or not. And from all the studies we have so far, the randomized studies, all the observational registries, we've known that only in half of the patients we attend TEER, we have a very good result, which is less than moderate. And only if we accept moderate result, then we go up to 70 or 80% of an acceptable result. So it's a procedure that in most cases we modify tricuspid regurgitation and we don't eliminate it. And that's why we have the option of TTVR, replacement, transcatheter replacement. EVOQUE is the only one that is currently approved. So the procedure is very similar to TEER. As Michalis thought earlier in case, we're coming with a device, it has 9 anchors, we gradually deploy the device, we make sure that we hold all the leaflets inside during all the stages of the procedures. The maneuvers are minute, once we're in the correct place and we have the correct alignment and coaxiality, and gradually we release the valve at the right position, achieving an elimination of the tricuspid regurgitation. So this valve, the EVOQUE valve, comes in 4 sizes, and basically it covers perimeter areas up to 160, 165 millimeters today, and the sheath of implantation is 28 French. So as you understood, the main acceptance criteria is the CT scan perimeter, and we also need to have prolapse of the leaflets. It should be restricted like to a certain area, a certain arc of the perimeter. If it's more than that, then we cannot go with EVOQUE. So imaging is very important, as Mihaly said earlier. MPR is crucial. This is an echocardiographic procedure, 90%, 10% is fluoroscopic. So everything is done with echocardiography, very important. Eyes may have a certain significance in the future when it's not fuzzy, as George said earlier. And then we deploy the valve, and these are the typical results we get without any paravalvular leak. And when we use the EVOQUE, we don't care if the TR is ventricular, atrial, primary, or lead related. Right ventricular function is very important because now we're not going just to modify the tricuspid regurgitation, but we're going to eliminate it. So if we have severe dysfunction or even moderate dysfunction in some cases, sometimes the right ventricle may collapse and it cannot tolerate the valve, and we may have a bad result. So it's more important to assess the right ventricular function with all the indices we know, TAPSE, TDI, GLS, and be sure that the patient has an acceptable right ventricular function. You have also seen this before, how to predict the result of the intervention using hemodynamic criteria, and also the RVPA coupling to combine in this index both the right ventricular function and the afterload, and the number is 0.4. If it's less than 0.4, then we have a problem. And in the TRISCEND study, these are the criteria that are used for acceptance for pulmonary hypertension. From this registry in a single center, we've seen that only 40% of the patients screened was eligible for TTVR based on anatomical and clinical criteria. This was before the advent of the 56 millimeter valve. So now we expect that this ratio is like 50% of the patients screened are acceptable. But if we go to see how many patients are not acceptable for TEER, for its category of TEER, favorable, feasible, or unfavorable, we'll see that only 1/3% of the patients who are not TEER favorable are actually acceptable for TTVR. So this means that if a patient is not good for TEER, it doesn't automatically mean that it's good for TTVR. Actually, only 50% of these patients are good. And this is also a prognostic criteria. If a patient is not good for TEER and is not good for TTVR, these patients have the worst prognosis. So this is the fundamental study, the landmark study of the EVOQUE, the TRISCEND 2, randomized 2-to-1 ratio, TTVR versus control, medical therapy, optimal medical therapy. So the main exclusion criteria was severe right ventricular dysfunction and pulmonary hypertension, typical elderly patients. Most of them had atrial fibrillation, symptoms of right ventricular failure, and of course, severe massive or torrential TR. For the procedure, the cardiovascular mortality at 30 days was 3%, and the pacemaker implantation rate was 24%. This is something to remember. This is a procedure like the self-expandable valves in TAVI that has a high rate of pacemaker implantation. The results, as you can see here, tricuspid regurgitation was eliminated in almost all patients compared to the control group, that there was no significant difference. And now we have these results to 2 years extended recently, sustained reduction. This was a positive study in this hierarchical endpoint, and the main factors were all-cause mortality. It was towards the right direction, lower mortality, not significant, of course, with EVOQUE. Same for hospitalizations for heart failure, towards the right direction numerically, but not statistically significant. And most of the significance came from the symptoms. That's why we say the indication is for symptomatic improvement, the KCCQ score. So this is a patient. We've done previous, as you can see, M-TEER, mitral TEER with 2 Pascal devices, a young patient with dilated cardiomyopathy that came back after some years with severe symptomatic TR. And as you can see, there was also a pacemaker, defibrillator lead there that was involved in the mechanism, so had no other option to proceed with TTVR with this very good result. This is another patient with previous mitral valve replacement, also young patient, as you can see, with beta thalassemia, no surgical option for redo. So we also proceeded with EVOQUE with a very good result. This is another patient with previous valve-in-valve, as you can see, with an accurate valve in the aortic side, and she had also to be treated for severe or rather torrential tricuspid regurgitation, an excellent result with EVOQUE. And finally, this is a patient that has it all. As you can see, TAVI, previous mitral TEER, and came back with treatment for his tricuspid that could not be treated with TEER. And also we implanted an EVOQUE with an excellent result, as you can see. This is a real-life experience from the European registry with the participation of our department. And as you can see, these patients, close to 200 patients, the reported results, elderly patients, typical elderly patients, most of them had atrial fibrillation, very symptomatic. Half of them had previous hospitalizations. The etiology, as you can see, of TR was mostly secondary, and actually atrial TR was more than ventricular TR, and they had acceptable right ventricular failure and RV PA coupling. And as you can see here, the procedure success was very high, and we had a very low rate of acute right heart failure or cardiac decompensation because these patients were very well selected. The RV function was acceptable. Pacemaker, close to 20%, 19%. And the other problem when we implant these large valves is halt and ham, as we see in the aortic area. So ham ratio was like 6%, as you can see, major thrombosis of the leaflets lower than 2%. And what happened after implantation of the valve at 30 days, we see that all the indices of right ventricular function were actually reduced, but this was compensated because the forward flow, because of the elimination of tricuspid regurgitation, was increased. So that's why the performance overall was improved after the implantation. And we also had some secondary observations like improvement of renal function and reduction of the bilirubin in these patients, symptomatic improvement in most of them. And this is the timing of the need for a new pacemaker, most of them, as you can see, within the first week. And the predictors of pacemaker were previous conduction abnormalities. And this is the real significant slide showing that patients that they had right ventricular failure, moderate or severe, before the implantation, they had a bad outcome, as you can see, compared to those who didn't. And these are the factors, the RVPA coupling, when it's low, when there is pre-existing MR more than moderate, when we have very high BNP, and when we have with patients with acute heart failure, like the one shown by Dr. Patsalis earlier. So these are the patients that we should avoid and we may not have good results. So these are some red flags or white cards from the USA from the implantation of the first around 1,000 patients. So the problems there were conduction disturbances that were reported. As you can see, the majority of them. There were also some malpositioning within the first 24 hours, basically after the procedure. If you don't see it after the procedure, it's very unlikely to see it later, and leaflet thrombosis. The future is coming with more valves than the Evoque that is currently approved. This is a patient with a 91-year-old with severe tricuspid regurgitation due to carcinoid, that there is no tricuspid valve, as you can see. And so this patient was rejected because of size criteria. For Evoque, you see a large hole in the tricuspid valve. So we explore the possibility of compassionate use of this valve. The Lux valve that comes to very large sizes, it was accepted, and we proceeded to implantation of the Lux valve. It happens from the jugular vein. You can see the large sheath there, and then you can see the capsule of the valve that comes into the tricuspid annulus. Then we have two ears that are capturing the posterior and the anterior leaflets, and then we have a tab that sticks to the interventricular septum, and then there is, as you will see here, a needle that has it's like a spider, and that it comes to stabilize this tab on the septum, and this is the result. A very stable position. These valves come up to 75 millimeters of diameter. So size-wise, it should be good for most patients that are not good for the Evoque valve. And with this excellent result, both immediate and clinical improvement of the patient after some long time, you can see how the valve appears here. And there is the study that supports the Lux valve that hopefully will soon get approvals for commercial use, the Trinity study. You see the sizes used in this study, 160 patients, cardiovascular mortality at 6 months close to 4%, non-selective tricuspid surgery and innovation from complications 2.5%, and lower pacemaker than the Evoque study, as you can see, 12%. Improvement in the symptoms in all these patients, and also improvement in the 6-walk minute test. So in summary, tricuspid regurgitation requires a multidisciplinary approach for the patient assessment and evaluation. To discuss the treatment options are evolving all the time. So what we know today, it may not be what we will know after 1 year. Selection of the therapy depends on the mechanism of regurgitation, disease states, quality of imaging, anatomic factors, and patient risk profile. TTVR is certainly safe, but more invasive than TEER, expands the access to treatment for many patients not eligible to TEER, and safety will likely favor transcatheter repair with TEER when feasible and when a reasonable result and effectiveness is expected. Whereas transcatheter replacement will be for those that repair is not feasible or the expected result would not be the reasonable we would desire. And with this, I'd like to thank you for your attention.
Great. We have Dr. Vlasis Ninios waiting for the live in box. Any comment from Dr. Athanassopoulos, Dr. Shuvy?
Thank you once more, Kostas, for your very, very innovative contribution. I was impressed that in your nice experience with the expert centers with this cohort of 145 patients, the fractional area change of your cohort was quite high. The mean was 42%, which means a proper volume loading of the RV. So this number is far beyond the limits which has been stated in the guidelines, which means that we're dealing with real severe tricuspid regurgitation. And probably, Kostas, this is related to the fact that the results of the TRISCEND 2 are better, according to the recent publication in the European Journal, are better for those with torrential TR. And my concern, George and Dr. Shuvy, is that probably what we categorize as severe and not torrential TR are not real severe TRs. So there is a kind of overestimation by the color and all these conventional echo people in their approach of categorizing severity of TR. So I believe that, Kostas, it's a very nice scenario that you are giving to us with this expert centers experience, properly categorizing, George, the severity of TR. Because now we are confused. If we are taking seriously these reports, the recent reports, for example, that in TRISCEND 2 studies, in the TRISCEND 2 study, the patients who have the best benefit are those with not severe but torrential. What does it mean?
This means we need a better categorization of the severity of TR. And obviously, we heard in the initial talks that we also need a better understanding of what are the important symptoms, not necessarily severe symptoms, but concordant symptoms to a very severe torrential echocardiographic picture, and then proceed. To wait for the classic end-stage symptoms, it's just the boat is already missed. Yeah. Okay, let's go to Dr. Thank you very much, Costa, for this amazing presentation.